Hello everyone, my name is Dr. Natasha Datoo. I'm a pediatric hematologist-oncologist as well as pediatric palliative care physician, and I work and live in Vancouver, British Columbia, which is in Canada. I work mainly at the British Columbia Children's Hospital in pediatric oncology, as well as Canuck Place Children's Hospice, where I do my palliative care work. I'm very excited to be here with you today. I have been volunteering with Two Worlds Cancer Collaboration since 2019, mainly with the Sunflower Children's Network. And I hope today we can talk through some very common symptoms other than pain that affect children with medical complexity and children who require pediatric palliative care expertise. Some of the objectives today that we will go through is identifying common symptoms in pediatric palliative care, reviewing some of these symptoms, as well as including how to assess and manage these symptoms. As well as we'll talk a little bit about recognizing the importance of an individualized symptom management plan in these patients. I think in pediatric palliative care, one of the special parts of the way we assess and manage patients is every patient, we try our best to have an individualized management plan based on their disease, their overall trajectory, as well as their goals of care. So we will try our best to go through some of that today. So although pain is a very, very common symptom that we see in children with serious illness, we also see other symptoms. So if you look at a few studies here, these studies are about 10 years old, but research does show very similar findings that overall pain is often in the top 3 to 5 symptoms that people report when they are dealing with serious illnesses, whatever that may be, oncologic or non-oncologic. However, there are other symptoms that sometimes come above that, and we will talk more so about those symptoms today. So we won't be going through management of symptoms at end of life or through imminent dying today. However, when we review symptoms at this phase of life, pain is absolutely usually the most common symptom. However, most people also report significant fatigue, nausea and vomiting, dyspnea, as well as constipation or other GI issues. So the body systems that we find that are most affected during the end of life or imminent dying phase, or in a child who has a serious illness who is having unmanaged symptoms, include GI systems, nausea, vomiting, constipation, respiratory symptoms, including dyspnea, and neurologic symptoms, which also include fatigue. And we will also talk about other neurologic symptoms that are often affected. When we talk about children with cancer at the end of life, we see that there is a lot of suffering related to unmanaged symptoms. So pain is a symptom that we actually see here, and the suffering from pain is here. When we look at how well we treat pain, we see that pain is actually one of the better treated symptom that we can help with. We have good pain medications, we have different routes we can use, and we have multiple modalities to help with pain. Other symptoms, such as dyspnea, anorexia or poor appetite, nausea, vomiting, constipation, potentially diarrhea or fatigue, are less well managed. So their treatments are less effective. And that's because they are often under-recognized, they're often under-reported, and we often don't have as much of a robust toolkit to treat these symptoms. So they actually can cause more suffering than pain in serious illness or in imminent dying. So some of the key points, just in terms of the beginning and how to assess these patients, is we have to understand the diagnosis or the disease that the patient in front of us is suffering through. We also want to think about, in palliative care, the natural history and trajectory of these diseases. We want to recognize and identify the symptoms that are affecting their quality of life the most. We want to build a symptom management plan with the family based on the availability of medications as well as based on goals of care. We want to think ahead. That is one of the roles of palliative care, is thinking ahead and helping with some anticipatory guidance and planning, especially if families are going to be going home and or we anticipate that symptoms will change or worsen over time. One of the things I see is the meaning attached to symptoms can really affect how they are expressed. For example, if I have a patient who is going through a bone marrow transplant or is going through chemotherapy with the intent to cure their disease, they will tolerate higher levels of pain because the goal is to cure. However, if we have a child who is nearing end of life and does not have any options or hope for cure, their pain is often much more difficult or much harder for the family to see. And we have a lower tolerance or a lower threshold for suffering. And so we often increase pain medication more quickly in these patients. So when we talk about how to assess and manage symptoms in palliative care with a palliative care approach, we often think about 4 steps. The first would be to evaluate and assess, which includes an in-depth history of the symptom that is the most distressing, but also other symptoms. So we also think about the other body symptoms and review overall symptoms: eating, sleeping, drinking, nausea, vomiting. A full review of symptoms is necessary because these things can affect quality of life as well. We do want to treat any underlying causes if it's possible and appropriate in terms of their goals of care or location or resources. We always want to think about non-pharmacologic therapies, and then of course we often have to use pharmacologic therapies as well. So when we think about evaluating our first step in terms of symptoms, we think about the differential. So what could be causing the dyspnea? What could be causing the nausea and vomiting? If we have the access, we also want to think about collaborating with primary and consulting teams. So if this is a patient who is having hard to manage spasticity, do you have a neurology team that you could consult that is involved? The oncology team, the pain team, psychiatry, if these resources are available and or if they're involved with the patient's care. We always do want to think about the role of medication overuse and deprescribing prior to prescribing new medication. So a thorough medication review in children with medical complexity and serious illness is often very helpful because often they have a lot of medications and sometimes these medications can interact and cause side effects that might be contributing to the symptoms. We also want to think about using scales and assessment tools that will help us make an objective review, especially before or after an intervention. So scales. So there are different types of scales that we can use when we're assessing patients. One of them would be a self-assessment. We can also use observation, where nurses can have a scale and observe patients' behavior during their shift. And we can also use physiologic parameters, so objective measures, heart rate, vital signs, etc. These are helpful to document and communicate with other teams or our own team in terms of handover tools. They're helpful to use pre or post an intervention to see how effective it was, and they're standardized and objective. So this is a distress monitor. We don't need to use a fancy photo. We can really also use a numerical scale, right? In terms of how bothersome or distressing a symptom is, 0 being no distress, 10 being extreme distress. This can also be very helpful. The other side is after overall distress, we can look through practically what is affecting. So, how is this affecting their physical abilities? How is this affecting care? If parents have to help with care, how is this affecting their overall life? So then you break down the distress into practical pieces. So the Karnofsky Performance Scale can be helpful in usually children above 16. So adults use this often, and this can help with how overall robust is a patient. And this is often used in the oncology world, less so in palliative care, but it can be helpful. So 0 would be the patient is no longer alive, has passed away. 100 would be a completely healthy patient with no evidence of disease, no complaints, no physical symptoms or emotional symptoms. And I won't go through this today, but this can be Googled and put up on a wall in a nursing station, and it can be helpful. The landscape performance status is a similar idea, but used for children and validated for children 16 and under. It's easier, and I find more practical when we're talking about pediatrics. So this is looking at the Karnofsky scale over here, Lansky scale over here, and this can sometimes help prognosticate a little bit in terms of how fragile or robust a person is based on their scale. So if we look at the Lansky scale, which I tend to use more often because we take care of pediatric patients, if their score is quite low, under 40, they have severe restriction or decreased quality of life or restriction of activities. Somewhere in the middle, 50 to 70, they have mild to moderate restriction on activities. And above 80, they're usually quite robust and able to do the things they want to do. I would say for children, if you think about a child, what they want most and what all children want to do is to play. So even without scales, if you are sitting in a waiting room, or you're sitting, watching a child, if they're playing, I would say they're doing pretty good and they're feeling pretty good. But if they're not even able to play, I would say that is a significant effect on quality of life for a child. This is something called a palliative performance scale. This is a scale that is validated in adults, but we do use it in children, again, often to hand over to our colleagues in palliative care, because if you know this scale, you can have an idea of what a patient looks like, depending on what we call the PPS level. So a PPS of 20 or below in adults is prognostic and has shown to indicate they have short to long weeks to live, so very unwell with a score under 20. Over 80, they're usually quite robust. So this is a helpful scale. Again, I won't go through it too much, but can be very, very helpful in significantly unwell patients. So let's go through some symptoms. Dyspnea. Dyspnea is probably one of the hardest and most distressing symptoms that I manage in patients with serious illness. It is a subjective sensation of unpleasant breathing, or an uncomfortable awareness that you cannot catch your breath. It is not an objective observation. It is not their respiratory rate or their work of breathing. If a patient says they feel they can't catch their breath, they are dyspneic. The majority of children with cancer or non-malignant conditions develop dyspnea in their last weeks of life. So as children get more and more unwell with a serious illness, regardless of if it's an oncologic diagnosis, a neurologic condition, a cardiac condition, we do often see some level of dyspnea. The pathophysiology is often multifactorial, and we'll go through a little bit of that. How does a child describe the sensation of breathlessness? Because it's actually quite a difficult sensation, even for adults who have often more words than children to describe. So sometimes teenagers say they just feel tired. They just feel more fatigued because it's a lot of energy to try and breathe when you can't. They feel tight. It feels hard to breathe, wheezy. Sometimes they feel that something is stuck in their throat, or a pain or heaviness in their chest is often very common in teenagers in how they describe dyspnea. There are multiple causes of dyspnea. I will not go through all of them, but I think of them as pulmonary or non-pulmonary. And when you think about the causes of dyspnea, again, this is part of our assessment, and we think about, is there something reversible that we can do? Are they anemic? Can we give them a blood transfusion if it's accessible and within goals of care? Do they have fluid overload? Can we treat that? So the reason for the dyspnea is often related to their underlying disease, and we may not be able to fix the cause, but if there's something contributing to the cause of dyspnea that we can maybe manage, we should think about it. These are different scales for dyspnea. I would say that I often use this one the most down here. And if you have the ability to either print or put this on a patient's bed, I think it's helpful because they can just point to what they are feeling, how bad their dyspnea is, or you can use a numeric scale and just ask. So these are potential ways to treat any contributing or underlying causes, right? Like we talked a little bit about transfusions. If they are having any kind of asthma or reactive airways, can use a bronchodilator. If it's anxiety, is there an anxiolytic that can help? Secretions. Often fluid overload contributes to dyspnea, and we may need to decrease the amount of fluid a patient is receiving if they're receiving artificial fluid through IV or enterally through a tube. Non-pharmacologic treatments in dyspnea are extremely helpful. So opening the window can be very helpful. Having a fan, handheld fan that we can make, can be very helpful. Lowering the temperature in the room. Heat can cause worsening of dyspnea. Any position that is the most comfortable for a patient. So if they position themselves in a tripod position, that is the best position for them. We like to try and keep their mouth moist because dryness can make you feel more dyspneic. And I would just say that oxygen is actually not helpful in treating the sensation of dyspnea. However, often families want to do something, and if oxygen is available, they will try it. It's not going to harm. It might dry, which could make things worse. But if they want to try it, they can try it. But it usually is not helpful in the treatment of dyspnea. Breathing techniques, relaxation techniques can be very, very helpful. Distraction can be very helpful in treating dyspnea. So pharmacologic interventions, the main medication used to treat dyspnea is an opioid. So in children, morphine is the most common medication we use and the most studied. The sensation of dyspnea starts in the brain and can also go down to the lungs. So morphine actually physiologically works for dyspnea. It decreases the perception of dyspnea in the brain. It decreases the respiratory drive that the CO2 that's building up causes. So when you have high CO2, it tells your brain to breathe faster, and morphine can dampen that, so you calm down with your breathing. And it also decreases oxygen consumption by vasodilating the lungs. So you increase oxygen exchange in the lungs. All of these things are very helpful for dyspnea and have a physiologic reason. So morphine is actually very effective. However, families are very scared to use morphine. It is not masking their symptoms. It does not hasten death. It does not result in respiratory position when it's used for the right reasons and it's used at the correct dose. So I often have to discuss this with families proactively before using the medication for breathing issues, because there are multiple misconceptions, even among healthcare providers. So I would say learn and be comfortable and confident that an opioid will help with dyspnea. You sit at the bedside, you give a small dose. We'll talk about the dosing. It's half the dose for pain. You give a small dose and you sit and you watch. And you often will see children start to breathe better. If you have them on a saturation monitor, their saturations will go up and they calm down. And often it's the presence, your presence of being there and watching this with family, that will help them understand. But we do have to have those conversations with healthcare providers and families about using morphine in dyspnea. As I said, the dosing is 50%, so half of the starting dose for acute pain. Benzodiazepines can also be helpful because dyspnea can cause significant anxiety, and so benzodiazepines can also be very helpful. The dosing is here. Delirium. So we will talk a little bit about delirium. It is a syndrome of altered cognition and awareness. It's usually multifactorial, and it can wax and wane. That is the hallmark of dyspnea, or of delirium, sorry. Too many D's. It is very underdiagnosed in pediatrics, I would say. But it can come and go and wax and wane, and it is more common than we think. It's complex, difficult to diagnose, as I said, and it's most common in younger children and those with developmental delay. Again, it is quite common. It's more significant at the end of life or in imminent dying. And it can cause quite a bit of distress, so we really need to think about it. Think about it is how you diagnose it, so consider it, and consider it in patients who have a lot of predisposing and precipitating factors. So some of these predisposing factors include younger age, developmental delay, underlying condition that affects the brain, so whether it's a meningitis, encephalitis, brain tumors, or brain metastases. If you have those things, you have to think about delirium if you're seeing symptoms. Some of the precipitating factors include oxygen supplementation or mechanical ventilation, so someone who's very unwell, different medications or polypharmacy, use of physical restraints, and the length of time they've been unwell or in a hospital setting. There are a lot of scales related to delirium. I'm not going to go through all of them and related to time, but the Cornell assessment of pediatric delirium can be very helpful. It's done by the bedside nurse, usually twice daily. So they go through these questions at the beginning of the shift and the end of the shift, or the beginning of their shift and the next nurse at the beginning of the shift, and this can be helpful to see if it's progressing or improving. Again, this is a different scale, can be helpful in nursing assessments specifically as well. So atypical antipsychotics are usually first line and usually readily available in most settings to treat delirium, and start with a very low dose. They all have significant risks, usually extrapyramidal symptoms and cardiac risks, but depending on the goals of care of the patient, this may not be as relevant, but you need to keep that in mind. And again, depending on the goals of care or the trajectory, you may need to check electrolytes or a cardiac ECG. But if this patient is imminently dying and this symptom is distressing, then I would say you don't need to check those things. You would just treat. Pharmacologic management. So here we have some haloperidol, quetiapine, olanzapine, risperidone, and I have the dosing here for you. Spasticity. So spasticity is very common in pediatric patients with serious illness, patients with cerebral palsy, patients with neurologic or metabolic conditions can often suffer from spasticity, which can be very distressing, not only for the patient, but also for the caregiver. It can significantly affect care. So care of the body, changing diapers, baths can be very affected and hard for caregivers in children with untreated spasticity. So it's an involuntary velocity-dependent increased in muscle tone. We talked about it's very common in children with severe neurologic impairment, also HIE, right? These are all very common conditions, and most children have spasticity. It's an upper motor neuron injury, so starts in the brain, and includes muscle weakness, but hyperreflexia as well as clonus. We use the Ashworth scale. So this is the modified Ashworth scale. Again, I'm not going to go through it related to time, but it is helpful, again, to think about when you're thinking about the severity, and see how patients can improve with treatment. Cerebral palsy. This is a helpful way to think about cerebral palsy. So we have level 1 to 5 for the GMFCS scores. So 1, a child can walk on their own. Level 5, they require a wheelchair for all of care and in between. Dystonia. Dystonia is a very difficult symptom to treat, I would say, and involves involuntary contractions of muscles. And it causes repetitive movement, unnatural positions, kind of a dancing, high tone situation, and can be very painful, very, very painful. Both spasticity and dystonia can lead to difficulty with sitting, sleeping, ambulation, speech, all of life, as well as care, and can affect quality of life significantly. It can really affect positioning in the chair, leading to bed sores, ulcers, etc. as well. So you need to treat the underlying condition. So if children with spasticity or children with cerebral palsy have other neurologic conditions or triggers that are making their spasticity worse, such as some sort of new pain or an illness, an agitation, you need to treat that, as it can worsen the spasticity that is at their level base. Common triggers that can affect spasticity or dystonia, or any muscle or movement disorder, and often worsen these symptoms, are some common things that all children can face. So if there's any type of pain, musculoskeletal, children with severe neurologic injury and are often in wheelchairs are at increased risk of osteopenia, and so fractures can be quite common, even caused by movement or changing position, or basic care. So this is something to always think about. Any other kinds of pain, for example, dental pain, dental abscess, ear infection, otitis, those can all significantly worsen spasticity or tone problems. Any other type of illness, so any respiratory illness, viral illness, any urinary tract infections, any type of constipation. So always look for constipation, reflux or GI issues, feeding intolerance, or any type of mood or emotional disturbance or change. So anxiety, sadness, all of these things. So if there's been a significant change in their home environment, this can also affect how children express themselves physically. So we always want to think about, in palliative care, providing goal-directed therapy. So sometimes we can do things, but it doesn't mean that we should. It may not actually be aligned with the family's goals of care, and may not actually benefit the patient, depending on the situation and trajectory. So our goal always is to provide comfort, ensure the patient is as comfortable as possible. We want to ensure that their day-to-day care is as easy as possible for the family. So one of the things we often think about with high tone is how difficult diaper changes, transfers from wheelchair to bed or bed to bath are. And so one of the things we often ask is, how long does care take? If it takes a long time because of increased tone, this would be a reason to intervene and improve the quality of life of the family and the patient. Improving function. So our goal is always to see if they are feeding themselves or able to play, we want to ensure that their tone is not affecting these pieces that provide them great joy often. So we often want to think about non-pharmacologic treatments first, like we've already talked about, for all of these symptoms, which include stretching, gentle massage can be very helpful, physiotherapy if accessible, and sometimes bracing and casting can also be very helpful. We often think about using an interdisciplinary team if this is available in the setting you work. So physiotherapy or rehab, neurology, orthopedics, and often the pain or palliative care team is involved to support the physical symptoms and emotional symptoms of these patients. So general pharmacologic treatment plans for patients where they have increased tone causing spasticity and or dystonia. The first line is baclofen, which is usually readily available in most settings, and this can significantly help tone. So you start low and you increase over the next few weeks based on the patient's symptoms and how much they're improving. Benzodiazepines can be used for the short term or sometimes as an as-needed basis, very rarely. I would not use this as a first line for the regular tone medication, but as an as-needed or for a short term, it can be helpful. So alpha-2 adrenergic receptor agonists, so things like clonidine, which is usually readily available, can be very helpful for tone as well. Most of these medications have similar side effects of sedation, and if we give them too much, can cause muscle weakness actually. So as I said, you always want to start low and check in over the next few days to weeks and see how the patient's tone is improving. Always think about considering treatment of any underlying triggering factors like we discussed. For example, if constipation is an issue, definitely try and work on the constipation, but you might have to work on the trigger as well as the tone. So you may need to work on the constipation, but also start something for tone at the same time, but do not ignore any triggers. If there's an acute infection, a urinary tract infection, or acute pain, you want to ensure that those are treated as well. This is just a summary slide of the dosing for the pharmacologic treatments for increased tone. Dystonia. So dystonia is a very tricky symptom to manage. Often we use the same or similar medications as spasticity. However, it is sometimes harder to get control of dystonia, and it can be a very distressing symptom for family and patients. If you have a neurology team available and if it's appropriate within the goals of care of a family and patient, they can often be very helpful in helping to diagnose dystonia, but also to manage it. And I will show you a care pathway that can sometimes be helpful on the next slide. So this is a helpful care pathway for looking at dystonia in patients with cerebral palsy. So you need to determine if dystonia is present with a neurologic exam. There are tools like a hypertonia assessment tool that can help us distinguish between dystonia and spasticity. If you diagnose dystonia, then the second thing to do, as with any symptom, is to assess the quality of life or how the dystonia is affecting the function of the patient. Always think about treating your triggers. And if it is affecting function or causing pain, review your non-pharmacologic therapies that we've already discussed for spasticity, which are very similar. I will mention, ensure that if they have a seating device, that these seating devices, so wheelchairs or even the bed, are not too small or the positioning is adequate, because sometimes that can cause pain and affect dystonia. And then similar to spasticity, for generalized dystonia, which is often the case, we would use baclofen. We can also try gabapentin, which is a very readily available medication. And then again, we've talked about benzodiazepines and clonidine as either a PRN or second or third line. So we'll move on and talk a little bit about constipation. Constipation is a very common symptom. for most patients with medical complexity or serious illness, and definitely for most patients with severe neurologic injury. This is a Bristol stool chart that shows us what type of hardness a stool is. So we often want to aim for a Bristol 5, 6, or 7. This is a soft, loose stool, not diarrhea. But however, it is often difficult to tell based on what kind of feed the patient is having, how much they're eating. So anything outside of their norm, if it is too hard or not as frequent, would be considered constipation to me. So I always ask the family, what is their normal bowel patterns? So prevention is probably the best way to start reviewing constipation. So we always want to think about those patients who are at risk. So any patient on an opioid or any patient receiving any zinc alkaloids in terms of chemotherapy, so that'd be something like vincristine, need a prophylactic stool regimen because they will become constipated without it. Maintaining an adequate and regular toilet routine, even while in hospital, which can be very difficult for our teenagers, but very important. So every morning, sitting down on the toilet, seeing if they can have a bowel movement. Maintaining privacy, again, very difficult in certain hospital situations, but we try our best. We talk about fiber, which can be helpful in patients with severe neurologic injury who can get fiber into them. However, in patients who are extremely nauseous, often the oncology population, this can be very difficult. We want to try our best to increase fluids, promote any type of movement activity. Walking, changing position for patients who cannot walk would be very important, and educating families and patients about constipation. So one of the things that we often talk about are oral laxatives. So we can divide oral laxatives into 4 groups. So we have softeners, bulking agents, osmotic agents, and stimulants. So softeners cause the emulsification between the fatty and the water components of stool in the gut, in the intestines, facilitating easier passage. So they join the fat and the water, and so the stool passes easier. Bulking agents actually absorb water and increase the bulk of the stool so it can get through faster. So it's heavier, and so it passes quicker. Osmotic agents actually cause retention of the water in the intestinal lumen. And stimulants actually increase the peristalsis through direct action on the walls of the distal bowel and colon. So just to note, for opioids, you have to have a softener and a stimulant. Rectal laxatives are things that we put through the rectum, so up the bum, whereas the oral laxatives that we previously discussed are either oral or enterally. So we have suppositories or enemas. So suppositories, we work by either causing direct lubrication of the stool or by stimulating peristalsis as you stimulate the rectum. And enemas stimulate peristalsis simply by the volume, by the amount of fluid that we put in the rectum. This is a slide I will not go through, but talks about many different kinds of laxatives and what type they are, as well as the dosing. So a few other pearls that I've learned is any patient who is on regular opioids requires a stimulant as well as a softener. So if a patient is on opioids, a softener alone will not suffice and they will have constipation. So there's a saying that the hand that writes the opioid writes the laxative. So they must be on both of these once you start regular dosing of opioids. And when you're talking about opioids, always remember that constipation is one of the side effects that remains. So for example, when you are starting an opioid, sometimes patients can feel nauseous or drowsy. Those side effects improve over time. Constipation does not. So anytime you're checking in on a patient on opioids, you must ask about their bowel movements. I would say that I try my best to use one agent from one class or one agent from 2 different classes and maxing it out. So increasing that one before adding another one, so it's not as confusing for families. One of the last symptoms we'll talk about today is nausea. So nausea is, again, a very common symptom in patients with medical complexity or serious illness, but it's often difficult to diagnose, especially in children with severe neurologic injury or any children who are nonverbal, because it is difficult to know how a patient is nauseous until they vomit, for example, if they cannot tell us. So this is a scale that we often use for patients who can either point or use even eye motions to point to one face or another to describe the severity of nausea. Some of the causes. So this is a helpful slide that talks about the pathophysiology and the centers in our body that cause nausea. So there's quite a few, but the four main ones are in the brain. We think about the cerebral cortex, as well as the chemoreceptor trigger zone and the vestibular system. So there is something called the vomiting center that is part of the chemotherapy trigger zone is included in that. And this is often affected by neurotransmitters that are released or circulating post-chemotherapy. The cerebral cortex is significantly affected and impacted by nausea and vomiting, especially if we have contributing factors of pain, fear, anxiety, raised increased ICP. And the vestibular system, so in the inner ear, absolutely can precipitate or worsen nausea. As we move down the body, the GI tract can absolutely be a center for nausea or vomiting. And this is often caused by any type of peristalsis. So any reason that the gut is slowed down and not emptying as fast can cause nausea. Usually, nausea is a combination of all of these centers. So there's usually something, for example, in the chemotherapy trigger zone, as well as the GI system, or the chemotherapy trigger zone, as well as the cerebral cortex that are affecting nausea. But I find this diagram helpful because it talks about not only the areas of the body, but also which receptors are the cause, so you can target your medication to affect those receptors. Okay, so for example, if you're thinking about chemotherapy-induced nausea and vomiting, dopamine, serotonin, and NK1 are the receptors that are most affected by chemotherapy to cause nausea. So in that sense, you would want to target those with things like haloperidol, metclopramide, aprepitant, or serotonin antagonists such as ondansetron if available. So it's helpful to know what the cause of the nausea is so you can target those receptors with the appropriate medication. That approach is actually very helpful in nausea. However, there are a lot of underlying causes that can contribute to nausea, and it's usually not one issue that's causing nausea and you can use one medication. It's usually a bit more muddy and difficult to assess. So I often do a full review of systems to ask about all of these things. So is there any evidence of constipation? Is there any evidence of gastric stasis? Is there any evidence of increased ICP in patients with brain tumors? What are their kidneys doing? As uremia can also increase nausea. If they've had chemotherapy, that can cause pancreatitis. You need to think about that. So reviewing what medications they're on or have been on or taken, their current symptoms, that will help you figure out what the nausea hopefully is from. And it is not uncommon that these patients are on multiple medications, and polypharmacy itself can cause nausea. One of the other things that is often difficult to assess in patients who are nonverbal is their emotional responses. So anxiety, sadness, all of these things can also contribute to nausea. So non-pharmacologic interventions for nausea. These are very simple on paper, but very difficult to do for families practically, I find, because families want their child to eat. Um, Depending on the goals of care, we all want their child to eat. It is a way that we show love to our children is by feeding them. So it's often difficult, especially in patients who are more comfort focused or whose trajectory is declining and they are nearing end of life, that we don't want to force feed a child if they're feeling nauseous and it doesn't make them feel good. So providing small meals, even bites chosen by the child, whatever they want or feel like eating. Give them a sip of their favorite drink, small sips rather than big chugs. Breathing techniques are very, very helpful. So deep inhales and exhales, any kind of meditation or hypnosis, these are very, very helpful in nausea, to breathe calmly and deeply. Good oral care, so moistening the mouth, brushing the teeth if appropriately, providing ice chips, all these things can be very helpful. Avoid any discomforting smells that they say trigger their nausea if they're able to tell you that. Certain aromatherapies and acupuncture, if available, can be helpful. So for nausea, things like citrus or mint, so peppermint, lemon, grapefruit can be very helpful for nausea. So antiemetics, as we discussed already when we were looking at the slide with the pathophysiology of nausea, I do find it is helpful to try your best to understand where the nausea is coming from, or the most significant part of where the nausea is coming from, if multifactorial, which receptors involved, and targeting your medication appropriately. You may need to use multiple medications to target different receptors. Opioid-induced or chemotherapy-induced nausea and vomiting are two that we will just review a little bit in more detail here. And again, if you think about nausea and a patient is not able to take anything oral, you can use things like IV or subcutaneous or rectal. So rectal medications can be very helpful, especially for younger children or babies, as you can do them with diaper changes and they absorb very quickly. So opioid-induced nausea and vomiting is its own issue, and one of the things that we can do if we are feeling that the nausea is related to an opioid is rotate to a different opioid. So if the patient is on morphine, you can try hydromorphone, vice versa, whatever is available to you. But if they're on an opioid and you're finding significant nausea, you could try a different opioid. If you have naloxone available to you and they are in a hospital setting where you have access to IV infusions, you could try a low-dose naloxone infusion. The other thing is any dopamine receptor antagonist, so haloperidol, for example, serotonin receptor antagonist, so ondansetron maybe can be helpful, or any anticholinergic or antihistamines. And absolutely, you must make sure that constipation is well treated, as this will absolutely contribute to opioid-induced nausea. For chemotherapy-induced nausea and vomiting, the first-line treatment is a serotonin receptor antagonist, so ondansetron, meclopramide. NK1 receptor antagonists are usually in the form of something called a prepitant, if this is available to you. I do find steroids, so dexamethasone or prednisone, can be helpful for chemotherapy-induced nausea, and they can also sometimes help patients eat a little bit more, depending on their goals of care. If they're receiving chemotherapy, this can be beneficial. Benzodiazepines can absolutely help if there's an anxiety component or a cerebral cortex component to the nausea. And dopamine antagonists, again, haloperidol or methyltrimepazine, can be very helpful if this is available to you. So here we reach the end of our very fast talk on symptoms other than pain. So in conclusion, symptoms are multifactorial and they're usually come with each other. So a child who's nauseous can often also have constipation. So focusing on a thorough history and physical as the first step in your assessment and plan can be very helpful and is necessary as your first step in managing symptoms with using a palliative care approach. Children as young as 3 can report their symptoms, so you can use scales that will help to assess the symptom severity and can also help pre and post intervention. Building a therapeutic relationship with the child and the family can help you to understand their goals, their values, their priorities, and their worries, which really help you formulate an individualized treatment plan, which is the key to palliative care, is we try our best to learn about a family, what's important to them, what their worries are, what their concerns are, and what they're hoping for the future, which can help us manage their symptoms in an appropriate way. Always think about pharmacologic, but also non-pharmacologic therapies, which can be very helpful. And definitely, if you have the capacity and ability to include the allied health team, so physiotherapy, occupational therapy, counseling, all of these team members are extremely important in helping to manage symptoms in palliative care and patients with medical complexity and serious illness. So thank you so much for watching, and I hope you learned something. Take care.